Now it's live stream. It's live. Yeah, now it's live. Go ahead, sir.
Yes, yes.
Sir, many are joining. Can we wait 5 minutes?
Yeah, you wait. Don't worry. Yeah. I am online just when you just talk to me whenever you are ready. Okay, मैं इधर उधर हूँ.
Already live on YouTube. I just want many to take advantage.
No problem. I am waiting. Don't worry.
Yes.
Yes.
Sir, many are joining. Can we wait 5 minutes?
Yeah, you wait. Don't worry. I am online just when you just talk to me whenever you are ready. Okay, मैं इधर उधर हूँ.
Already live on YouTube. I just want many to take advantage.
No problem.
Rishabh.
हाँ सर 12 participants थे हमारा.
You become mute and Sakla sir, help the Sakla sir to join.
This meeting is live streamed. Okay.
Sakla sir.
You become mute. Sakla sir phone करो 1 minute. So Shankla sir is joining in another 5 minutes. He's facing some problem by during joining. So he'll be joining in a couple of minutes. Till there, I'll just share.
Hello, hi, Jayesh.
Hello, sir. Good evening.
Good evening, sir.
Hi. Can you see me?
Yeah, yeah.
Yes, sir. Yes, sir.
Okay, okay, fine, good. So,
So, go ahead, sir.
is everybody?
Yes, sir. So,
Hi, Suresh. Hi, Suresh.
Hi, good evening.
Good evening. Let's begin now, Jesh.
yes,
I
sir.
think
Yeah,
so.
yeah. So, Rishabh,
Yes, sir.
yeah, stop sharing.
Good evening to one and all. Welcome to. Yeah.
You should start.
Yes. Can we request all the participants to please mute their videos? Yeah. Thank you very much. Good evening to one and all. It's a complete honor for a platform as young as ours to have two stalwarts from in the world of neurosurgery from Mumbai. We have Dr. Atul Goel and Dr. Suresh Shankla, who would be speaking on a very relevant topic, especially for the young pass outs and the ones who are going out of their bonds. We'll be having a small introduction for both the faculties by Professor Jay Sardara, and we'll be starting off with our dilemmas and getting our dilemmas answered by two stalwarts from the field of neurosurgery. So I hand over the proceedings to Dr. Jayesh, and I welcome all the participants who have joined in to get their dilemmas answered. Thank you.
Thank you, Rishabh. So, welcome you all. Good evening to all. This is very exciting webinar today. Why we requested both of these senior leaders to choose this topic and to talk one. There is a particular reason. The season of examination is over across the countries in many neurosurgical institutes. And now it's time to go next steps further for the young residents to become a young neurosurgeons. What to do now? There is a big dilemma. Should we go for private institute directly? Should we gain some experience in government hospital or institutes for some times and then move to the private hospitals? Those who are in the government hospital, they have their own dilemma. Where to move to the private hospital after? What is the cut of the lines? There are many questions in their minds. The most important questions regarding the fellowship and observership: what should we do, where, when, how, and when? How to choose subspecialty and how to grow in the particular subspecialty in the neurosurgery field. So this with all these questions in mind, we decided to have requested to share their experience with the senior leaders of the country, Professor Atul Goel and Professor Suresh Shankla. So many residents and young musicians are with us, and we are in live on the YouTube. So they are watching us in the live. Sir, your first of all, we'll listen both the seniors, and then the question answers will be taken at the end. So I would like to welcome Professor Atul Goel, sir. Sir, you are not only remain our ideal, because you all become the role model for all the young neurosurgeons across the country. Reason being, you are very friendly. We would like to have your wisdom, vision, and please share your experience, how to grow in our career, private versus government hospital, and what is your experience on that. Please welcome, sir. Yes, sir, please.
Jesh, I'm not able to share my screen.
Yeah. Let me make it. Just. Now you can, sir. Can you, sir?
Yeah. Can you see my screen?
Yes, sir. Yes.
So, my dear young friends, and my dear colleagues, and my dear, I am talking from a pedestal, which is quite you may call me senior, but I am quite young at heart. Still, I think I am quite energetic and stronger than ever before. But I have spent already 40 years of my beautiful life in neurosurgery. September 1982, I joined, and there is no question in my mind that these 20 years have been absolutely fascinating years for me. Neurosurgery is a tremendous and a very great subject. It is not a profession. It is a lifestyle. You cannot say, I go for 5 hours, make some money, have enough money to eat, and then come back again. It is not like that. It is a life. It is a lifestyle. You become a neurosurgeon and you leave rest of the world. So that what Dr. Jayesh told me to talk about what dilemmas one could face in neurosurgery, and he gave me 45 minutes to talk. So I have decided to talk about my 40 year of experience in neurosurgery and from where to where. So starting from zero, I came from this Government Medical College, Nagpur. This is quite a big institute, this is the college building, but it has one of the largest number of patient volume at that time. 3,000 inpatients were there at that time. Now, of course, it is much bigger. So I left this hospital as quite an ordinary student. I don't claim to be an extraordinary brilliant. My brother was, of course, a very high profile brilliance of this college. I was okay. And I was looking for general surgery after passing my MBBS. I did not get general surgery in Medical College, Nagpur, did not get it. So I moved on to Chandigarh, where I started neurosurgery, started general surgery, but I got into neurosurgery in Mumbai. That was a 5-year course at that time in Mumbai, and nobody used to take, actually most of the seats used to go vacant. And neurosurgery was no subject at all at that time. Neurosurgery, nobody knew. In our general surgery course, neurosurgery was just one chapter on head injury. Otherwise, in Love and Bailey, there was not a single mention about neurosurgery. So neurosurgery was a non-subject at that time. And neurosurgery, to take into neurosurgery, to get into a 5-year course, and to spend a lifetime. Many of my friends told me, oh, have you gone mad? Why the hell are you joining neurosurgery? There is, in 1982, nobody actually knew neurosurgery. Why the hell are you joining neurosurgery? Half the people are dead because of the problem, and half because somebody has operated on them. So there are almost entire ward full of dead people or half dead people, and you will have to work hard and this and that. And they were discouraging me like anything. But I joined neurosurgery, and I must say that I have never looked behind. I have loved this surgery. I have loved neurosurgery. I have lived neurosurgery. I have developed into the field. And as they say, nothing succeeds like success. Gradually, success came in my path, and I accepted that success with both hands. So neurosurgery was a foreign subject at that time, but somehow, I don't know why, but I accepted it. And you will be surprised that Ramamurthy, long time ago, got Padma Shri by President of India. And my mother was reading the newspaper when I was in 6th standard. And she says, my son will also become a neurosurgeon one day. You can imagine, this was the premonition in her mind. Never she knew, she was half educated. Never she knew what was neurosurgery, and never she knew what involves getting into neurosurgery. But this is what she had said. So somehow or the other, I entered into neurosurgery. And neurosurgery in 1982, I must tell you, you are very fortunate, but neurosurgery in 1982 was quite primitive, to say the least. There was no CT scan in 1982. In CT scanner came in Mumbai in 1983 or 84. And MRI came in 87 or 88. So to that extent, you can imagine to diagnose cranial lesions without CT scan on the basis of X-rays and on the basis of angiography and on the basis of other investigations at that time was quite, it was neurosurgery. There was no microscope. The lights were poor. The bipolars were not there. You can imagine there was no neurosurgery at that time. It was, of course, there were stalwarts. Of course, people were there. And of course, there were big names of neurosurgery in India and in the world, but neurosurgery was quite primitive. And the first day when I entered into the neurosurgery operation theater, Dr. Vengsarkar, my boss, was doing a posterior fossa tumor. And he had put a ventricle in the lateral ventricle, a brain needle, and there was some CSF coming, and it was quite a dangerous kind of view for me when I came in and stood behind him. And they were like kings, neurosurgery. Dr. Vengsarkar and the entire team were very high-profile people of the hospital, but they were doing without microscope, with all kinds of difficulties they were doing. But no question that their teachings and their strong shoulders have put us where we are today. Neurosurgery as a subject, we all know, was quite primitive, and gradually, slowly, surely, definitely it has advanced to the extent that today neurosurgery is an absolutely game changer, life-giving. You do good neurosurgery, you give new life to the person. You do bad neurosurgery, you kill the person or you demolish the person. So the first message I want to give to the young people is, if you have taken the subject of neurosurgery, you have to dedicate into the field. You have to put your time into the field. You have to give your life to this subject, because if you are operating on an individual, you can actually give new life to the person. You can give new, complete, normal life. And if you don't operate properly, you can demolish. So you have to learn. And there is no other way. There is no question of whether to have any other kind of dilemma. There is no dilemma other than hard work, dedication, aspiring to become big neurosurgeon, aspiring to become a good neurosurgeon, aspiring to become a top neurosurgeon. You see, I have already told you that I was not out of the world medical student. But one thing I had in me, it was ambitiousness. I wanted to become a big man. I wanted to become a huge surgeon. But when I came into neurosurgery, that ambition suddenly blew and grew. And I thought that this is my opportunity. And I have to, believe me, I have never looked behind. And that opportunity that neurosurgery gave me at that time to become big in the subject, to my ambition was, even when I joined in 1982-83, that I want to become the world's best. And this kind of talk was going on when I used to talk to my father and my mother and all those things. Ambitiousness was there. And believe me, for a neurosurgeon, talent is one thing. You have to be, of course, talented. Second most important thing is to be ambitious. And the third and the most important thing that you young guys are looking for is opportunities. You have to have opportunity to become big. If you are good and you are talented, but you don't have opportunities, I think your ambitions may be curtailed. So because of God's grace, I got wonderful opportunities in neurosurgery. And that is how I am where I am. So in 1982, you will be happy to know that clinical diagnosis, the importance of jerks, importance of planters, importance of higher function examination, importance of speech examination, examination of vision was so critical, because these were the diagnostics. There was, on the basis of, you can imagine, on the basis of X-ray, what you can diagnose. On the basis of X-ray of lumbar spine, what you can diagnose. On the basis of angiogram, what you can diagnose. So angiogram was very important instrument at that time for radiological diagnosis. And this was a pneumoencephalogram. You will be surprised that we used to put air in the lumbar space. We used to hang the patient on a table, and that table used to turn from one side to another with upside down. And that air we used to take inside were tremendous. And imagine, on the basis of this pneumoencephalogram, how much you can diagnose and how much you are sure as to what you are going to do and where you are going to operate. So it was a difficult time at that time for neurosurgery. Angiogram, we were fantastic in angiogram. You'll be surprised that all head injuries, when they used to come, there was no CT scan, nothing. We used to diagnose on angiography. And where is the Sylvian point? How is the anterior cerebral artery displaced? How is the MCA displaced? We were quite good, but the information was only here and there. It was not a tremendous information that we could get from angiography, but we could get. And on venous phase, what is venous angle? Many of you may not be even knowing these things so well, but they were the diagnostics at that time. Myelogram came into picture with myodil injection, and here you can see the tumor. And myodil was a big invention. Myelogram was a big invention after about 30, 40 years of total dependence on X-rays and total dependence on angiography. The things went further. You will be surprised that when I was a registrar, I used to make operation list, and one of my operation lists, sometimes I used to mention exploratory craniotomy. Can you believe exploratory craniotomy is like exploratory laparotomy? We do not know what we are doing. We do not know where is the tumor. We do not know where is tumor or whether there is no tumor. So it was all arbitrary, and we went for exploration of the brain. And sometimes there were negative exploration. Imagine you have taken the patient and you have come out negative. And imagine the situation, and it has happened in my own lifetime, that there was a tumor on the other side and we had operated on the other side. There was extradural hematoma on the other side and we had operated on the other side. So these kind of problems were quite galore in 1982 in my own lifetime. And we have developed and generated from that situation. And then came the era of CT scan. You see now, this is the huge CT scan, a huge meningioma. Imagine with X-rays how much you can diagnose. You could have diagnosed a little bit on angiography, but when the CT scan came, then we could see the size of the tumor. We could make the flaps. Even the flaps were very standardized at that time. There was a frontal flap, like extending from here to here. There was a temporal craniotomy flap, which extended like this. There were exploratory burr holes. For head injury, we used to do exploratory burr holes. There were 4 standard burr holes we used to put in trauma situation. And then you can imagine the situation. And surgery on meningiomas was not easy. Dr. Venserker even tried, cooling the head and cooling the brain to reduce the vascularity of the tumor. And I was supposed to cool the patient using ice packs. We used to rub ice on the patient and things like that. So it was difficult, not only in India. You don't underestimate, one thing is, you don't say that this was the whole norm in the whole world at that time. Maybe we were here and there 1 or 2 years behind, but this was the thing. These were the things which were going on. Then came MRI. And you see MRI, the carotid artery is encased, the tumor is on both sides of the dura. This is how in 1986, 87, 88, skull-based surgery was born because of introduction of high-quality imaging. And fortunately for me, I was erupting at that time on the basis of very extensive dissections on cavernous sinus, which we started doing. I started doing in 1984, 85, 2 or 3 years after I joined neurosurgery. And if you can say that I have done something, I have done only an extensive dissection on cavernous sinus. I gave my first presentation of cavernous sinus anatomy in departmental meeting in KEM Hospital in 1986, where I gave a full lecture on the basis of my dissection on cavernous sinus. You see the tumor. This is diagnosis on the basis of MRI, carotid artery, how the arteries are encased and how you have to plan. The whole world has changed after MRI has been introduced. For spinal tumors, you can imagine for myelogram how much you can see, and MRI how much you can see. You can see exactly the relationship. You can make a diagnosis of benign tumor, malignant tumor, aggressive tumor, intramedullary tumor, extramedullary tumor. And there were parameters on the basis of myelogram. We used to do Conray ventriculography and things like this. Of course, I joined in 1982. And during that time, the whole neurosurgery was changing, because in 1983, early 1983, in Raheja Hospital, first CT scanner came into Mumbai. And then there was a stream of CT scanner, MRI in the city of Mumbai. Then came revolution in diagnosis and treatment. These kind of tumors, low-grade tumors, you see, these kind of tumors could not be diagnosed on angiography because the vessels are not displaced. So this entity of low-grade glioma was introduced in the world of neurosurgery after MRI came. Otherwise, nobody knew exactly what are low-grade gliomas, because they were not diagnosed, because they were having minor symptoms. Angiography was not good. Ventriculogram was not useful. So these tumors like cavernomas in the brain, this entity has come only after the introduction of MRI. This kind of cysticercus and multiple tumors, these were not diagnosed on the basis of any investigation. You do angiogram, it will be normal. You do ventriculogram, it will be normal. The person will have convulsion after convulsion, but MRI changed. Then, of course, the whole world of neurosurgery changed on the introduction of microscope. And microscope is the life of a neurosurgeon. And there is no question, life without microscope cannot be neurosurgery. Neurosurgery is microscope, and microscope is neurosurgery. The patient was highly uncomfortable when we started. You see, the tables were not good. The tables were flat, this kind of positioning, sitting position, lateral position. Now we know the chairs are there, the microscopes can, and the surgeon can be sitting, the patient can be in comfort. The whole world of neurosurgery has changed during my own lifetime of 40 years of neurosurgery. And this journey I'm going to discuss with you. Then this came with interventional radiology, coils and image-guided surgery and stereotactic surgery and navigation and things like that. So what I want to show you is my own journey, first with Dr. Vengsarkar, who in 1982, who was my boss. And this kind of relationship that you are seeing was not always. You see, he was a very tough man. He was Mr. GMC, KM, means he was a muscle builder. In his later part of his life, he started laughing and smiling with me. Otherwise, I could not even imagine touching him on his shoulder. He was a tough man. And he was a very, very fantastic basic teacher of neurosurgery. But he never used, microscope, basic teaching of neurosurgery, and a very high level of teaching, and a very, very nice man. And it was my great honor to be associated with him. Then, of course, I joined neurosurgery in KM Hospital, which has changed my life. This has been my temple. I lived in this hospital from 1985 to just recently. About 38 years of my life I spent here. And at the age of 27, I became a neurosurgeon. And at the age of 37, I became head of this great institution, which just changed my life. And this, if you really ask me, one, I said, is your own talent. Second is your ambitiousness. And third is the God-given opportunities. If you get opportunities, neurosurgery, you cannot be artificial. You cannot be having ego. You cannot have pseudo pride. You have to be real. You have to be result-oriented. You have to give the results to the patient. And that result you can get only if you are operating on a regular, daily basis. And this hospital gave me an opportunity where I was operating continuously for 38 years of my life. And whatever I am, I am a product of this hospital. And these were my teachers in KEM Hospital in 1985, Dr. Sunil Pandya, Dr. Karapurkar, Dr. Nagpal, Dr. H.M. Dastur was before Dr. Pandya. He retired in 1997 when I took over as head of department. So from 1997 to 2022, for about 24 years, I was head of this great institution. I was head, all right. Hospital was okay, all right. But the kind of people, the ethical king, Dr. Pandya, Dr. Nagpal, Dr. Karapurkar, Dr. H.M. Dastur, if you just see his face, he is alive even today. You just see him, you bow down with great respect. And one gentleman you are seeing behind is Dr. Manu Kothari, who completely changed me, who made me philosophical, who made me go thinking beyond what is normal and what is natural and what is existing. Tata Memorial, I have been associated for good 30 years, and this has been also one good milestone in my career. The question is, Indian situation, whether it is good or bad. I am saying it is not good. It is absolutely excellent. You know, for neurosurgery, we need microscope. We need a good bipolar. We need a good suction machine. We need some basic instrument. And what we need most is the number of patients, the volume of the patient, the quality of the patient, the complexity of the problem that we are going to face. And nobody in the world can give you this opportunity like what India can give you. So we don't ever, you see, this was one thing in my career, everybody used to say, we are not going to do good neurosurgery because we are from poor country. And I think in 1986, 87, I said that we in India can do the best neurosurgery of the world because of our volumes of the patient. And I have actually recorded this, and maybe I like to read that recorded statement when I said that Indian neurosurgery can be top in the world on the basis of our volumes of patients. And suppose you have operated 100 acoustics, and suppose another gentleman has operated 2,000 acoustics. No matter how talented this 100 fellow is, but 2,000 gives him the confidence, gives him the experience, gives him an opportunity to handle the situation, go through the situation. So another very important message I want to give to the young people: you have to go for volumes, and that should be your power. And if you go for volumes, if you go for quality, if you go for complexity, you are going to grow. There is no bargaining in this issue. There is no two-way. You have to go for volumes. And you have to learn the anatomy of this beautiful, magical organ called brain in depth. This fiber dissection and all were not there. Nobody knew what is white fiber and all those things at that time. This has grown in my own lifetime of neurosurgery. This understanding of amygdala anatomy, hippocampal anatomy, thalamic anatomy, these were there, but they were not exactly to that extreme. Albert Roten, many of you know, introduced modern neuroanatomy in the world of neurosurgery from 1978. His papers are not before that. Yasser came into picture in 1970s. You see, these kind of people have then introduced microscopic neurosurgery. And, in my KEM hospital, microscopic neurosurgery was, I forgot to tell you that Dr. Pandya was amongst the first micro neurosurgeons of Mumbai. And that gave me an opportunity to work with microscope. You will be also surprised that we have endoscope first time in India in 1987 or 86. We had all kinds of tables, all kinds of microscope was gifted by Pia, German neurosurgeon, to KEM. Then, of course, KEM bought many other microscopes. And these were in 1984, 84, 85. These were my own dissection and a lecture I gave in Department of Neurosurgery at KEM in 1986 on cavernous sinus. Not many people in the world knew cavernous sinus. You will be surprised that in 1992, I was invited in Japan to do a live cadaveric workshop on cavernous sinus, because I used to talk on cavernous sinus anatomy. In 1991-92, I gave first workshop in Shinshu University in Japan. Then I have continuously in various Nagoya, Osaka, in Singapore, in China, in various places, I did workshop when I was hardly 32 or 33 years. So age should not be a factor that you should limit yourself. You should never say, I am young and I cannot do and this and that. Age is, we did dissections. And of course, when, I was 26, 27 years old, we introduced the world famous technique of C1, C2 fixation on the basis of cadaveric dissection. So now today, technology is, of course, very fantastic. Techniques are important and techniques have to be learned. Technology has to be acquired, but techniques have to be learned on the basis of hard work, on the basis of dedication. I have already told you, neurosurgery is a life. Neurosurgery is not a profession, is a lifelong learning, because it is so important to learn and to contribute to the patient. So technique is there, but this gentleman, Dr. Manu Kothari, introduced philosophy in me. And that philosophy, I am not sure how many of you have read my work with Dr. Manu Kothari. Huge number of philosophical papers, more than 40 papers or 40 philosophy. You can see some of these papers on neuraxial healing, equalization of neuraxis, on muscle, on brain abscess, on anticytosis, on various kinds of philosophical papers. And I have no hesitation to say that no neurosurgeon on world talks about philosophy, and my association with Dr. Manu Kothari made me different, because I started talking on philosophy for the first time in the world and for the last time in the world of neurosurgery, and several papers on this subject. We introduced that cavernous sinus has a role in eye movements itself. We introduced that it has role in vision and in several other respects, something which nobody had ever discussed in the literature. Then came my relationship with Dr. Lahiri. Many of you have heard him. Many of you have known him through my own papers. He's an orthopedic surgeon. And he was an absolute dedicated anatomy man, cadaver dissection. He was in anatomy. You will be surprised. In 1984, he came to me and he told me that for lumbar disc, we do not need any diagnosis. He told me by the way the pain goes, we can make that it is L4-5 disc or L5 disc, S1 disc, and you can operate, because myelograms were here and there. And this gentleman introduced what kind of dissection we used to do together. You can imagine he was an orthopedic person, and he used to come, and I used to do glove suturing in 1983 in my anatomy lab. Suturing of glove under microscope is a beautiful exercise, and those who are not doing must learn how to suture under microscope. You take a small rent in the glove and suture, and everybody should do. There is no hanky-panky. You see, I don't want, and this nonsense will not work. And this gentleman introduced to me to the world of craniovertebral junction, and we used to do from 1983 continuous dissection, transoral surgery. Then in 1987 we did introduce this technique. At that time, screws. What were screws? No neurosurgeon used to know. Even now, many neurosurgeons do not know what screws are, what facets are, and how to do fixation. Lumbar screws were just introduced in 1986. And 1987, we introduced this beautiful technique of screw and plate fixation. In 1988, we introduced another technique, transoral. We removed this and did this transoral. Of course, many of you know that I don't recommend this, but you can imagine at the age of 27 or 26, we introduced these kind of techniques. We got the opportunities. My institution provided me this opportunity, and cadaver dissection gave me an opportunity. So over the years, I made several wonderful friends in neurosurgery, and many of these people are very well-known names. Here is Peter Janetta, Kobayashi, Hakuba, a very well-known person. And if you see this picture, I'm in operative dress. Can you see in operative dress? Because I was the one conducting workshop. Here is Kawase. Kawase is triangle, you know. Kobayashi, no. Kiyoshima, you must be knowing. I was conducting the workshop, and all these, even Al-Mufti is not here, but Al-Mufti was also in the program. And if you see, I am conducting a workshop here. in 1992. So these, you can read the 1992 here. And this was also in 1992. So these kind of anatomy has just taken me where I am. And there is absolutely no question. This is Sydney Peerless. This is Laligam Shekhar, Peter Janeta, and things like that. And this, my family has to be, if you have to be anywhere, you have to have a nice little family, and you have to love the family and dedicate your life of neurosurgery. And if you have support, now my daughter, here is my daughter, and she's also a neurosurgical resident. And I have achieved what's nothing succeeds like success. And today I have got 740 PubMed publication and various awards like BC Roy, Dandy, and all those things are okay. But what has been my life has been a life, I can say that wonderful life of neurosurgery where opportunities came my way and I used them. Opportunities, many people get the opportunities, but whether they will be able to use it or not. So this is in 2011, 1996, this book with Professor Kobayashi I wrote was reprinted 3 times by Churchill Livingston. Churchill Livingston was a great, biggest name in publication. Gray's Anatomy was by Churchill Livingston. And another thing that you will be surprised to hear, that in this book, all the techniques, even the cover page, were my own personal techniques. The whole book was, the entire line drawings were my personal techniques. More than 150 techniques I introduced in this book, all of them published and all of them personal. And then I got various awards, various opportunities to give lectures all over the world. And you will be also surprised that how neurosurgery has taken a man from zero to the highest level in neurosurgery. So you'll be, if you can read this, I am now ranked by Stanford University ranking #1 in the skull base in the world and #2 in neurospine in the world on the basis of publications, on the basis of impact of publication, and on the basis of contributions. So this is independence, and this is a published survey. And there are many publications in highest in this and this and this publication. So another very important thing I want to talk to young people is you have to write, you have to contribute. You see, you cannot say that, no, I cannot introduce new ideas. And I know Jayesh has written some beautiful articles. Many of you have written. You have, one is to operate and one is to write. And both of these things are important. So in my career, the thing was not to answer all questions, but to question all answers. That was the motto which was given to me by my teacher, Dr. Kothari. Of course, these are not egoistic. This is not, philosophical, but this worked in my favor. The other thing is philosophical. Dura is the mother of the brain. On the basis of this concept, you'll be surprised that at least 40 articles I wrote about how the tumors respect the dura and how the dura respects the tumors. And this forms the basis of many of my contributions, which I will show you. And what about primacy of the soft tissue? We the spinal does not pass through foramen magnum. It is foramen magnum that develops around the nerves. Mandibular nerve does not pass through foramen ovale. Mandibular nerve comes first. Soft tissues are strongest. Bones are the weakest part of the human spine. This was some beautiful lectures you might have heard from me. I'm not sure. So how a brain of 13 billion neural cells and 130 billion glial cells and 100 trillion cells, how they are born from 2 cells is an absolute miracle. And in nature, there is no space too small, no task too big. So we should be like a child. We should think about neurosurgery as curiosity with sense of wonder, sense of admiration. And you should think how ignorant you are when you look at the stars, when you look at the sky, when you look at the life, and when you look at the plants and animals. You should have in nature's infinite book of secrecy a little I can read. So these were my initial papers where I said that shunts are not required for brain tumors. You'll be surprised when I came into KM hospital, there were 260 shunts per year being done in that hospital. And you will be also surprised for last 25 years, I've never done a shunt. So this was my philosophy. And I wish many of you or some of you must read this philosophy as to why shunt is not required. We said that hydrocephalus is a natural protective phenomena. When you do a shunt, it goes towards the brainstem and it can be a negative. This is the tumor, the contralateral ventricle is dilated. If you drain this tumor will be herniated here. So we said that this brain edema, hydrocephalus are all natural protective, do not shunt. And these were my papers 32 years ago. So you can imagine, and this another tumor obstructive hydrocephalus, a natural defense mechanism, tumor-induced edema, a natural defense mechanism. And many of you have heard my lectures on syringomalia, a natural defense mechanism. Chiari, a natural defense mechanism. Recently, if you have not read, please read The Disc Herniation is a Natural Protection, and many other natural protection. Bone fusions are natural protection. So bleeding and hemostasis are what neurosurgeons should learn. When it occurs, when the bleeding occurs, how to achieve hemostasis. And this cannot be learned by superficiality. It has to be learned on operating. You have to learn how to demolish the tumor, how to break the tumor, and how to come out successful. Blood is an absolute miracle, and how bleeding occurs and how blood is our life. How one neurosurgeon is different, how Jayesh is different from Rishabh, or how this doctor is different from this doctor, as to how he reacts when there is a bleeding. When there is a bleeding, some people shout, some people raise their blood pressure, some people just start coagulating. Response to hemostasis and how the way of hemostasis makes us what we are. How to have hemostasis, how to learn tumor handling, how to do microdissections have to be learned on the basis of volumes of patients. And there will be God who will be helping you when the bleeding occurs. And these kind of quality tumors, this was the largest tumor ever, largest meningioma ever operated in the history of neurosurgery. And I gave one lecture on meningioma in Japan long time ago. And that was a meningioma meeting organized by Professor Kawase. And I said that Mount Fuji is smaller than the Indian tumors. And this was successfully removed, 1,400 grams. These kind of tumors, this slide of mine is a very favorite slide where I said that the tumors can be like a lion and you have to tame the lion. You have to tame the lion very beautifully. And if you tame the lion, it will look like a flower and you can remove it beautifully. It can look like various kinds of animals and dangerous animals. So you have to learn how to make this. So I got this opportunity. I became head of department in 1997. And from that time, you can imagine from KM Hospital, the volume of patients and the freedom. The most important thing in KM Hospital is one, the volume. Second is there are layers of protection for you. If you create a complication, there are protection and you are not troubled. In private institution, what can happen is if you create a problem, you can be troubled quite miserably. And you can, one or two cases go wrong, and you can be troubled for a very long time. So that is the advantage of hospital like KM, where the layers of protection are there, and you don't get troubled. One neurosurgeon, when a fellow came to me in long time ago, he said, "Dr. Goel, you are the most relaxed neurosurgeon of the world, even when you are doing so many cases." So 1993, you can imagine this tumor. 1995, 1995, 1997, some of the biggest, beautiful skull-based tumors I did. This tumor was the most vascular tumor I ever did in my lifetime. This was done in another hospital. When he came, the doctor came and did biopsy. He lost 4 liters of blood. Then he was sent to me. I did total pitrosectomy at that time. Before I reached the tumor, I lost another 4 liters of blood. I sent this guy home saying that no operation is possible, but he came back with severe giddiness. And then I did angiogram. I tried to block the artery, but he didn't. Balloon at that time we tried to do, but he developed weakness, so that balloon had to be deflated. But I did beautiful technique in this patient, and I removed this about 25, 30 years ago, you can imagine. And it was a ossified glomus, and this man is still alive. So there is a possibility of giving new life. This is another patient who had a huge tumor. And of course, it is a malignant tumor, but by surgery you have given. And this lady came to me smiling with a big defect here. And then she was lost for follow-up. So it is in your hand. You can give fantastic. AVM surgery is another beautiful. So nobody in the world can have what experience we have generated over the years. These are difficult operations. Hemostasis, dangerous. Microvascular dissection, anastomosis, removal of the tumor, small vessel, big vessel, multiple vessel bleeding. AVM is an ultimate test of a neurosurgeon. Last chapter of neurosurgery. This was one tumor with patient presenting with only giddiness, and I removed this tumor AVM beautifully. And I'm not sure this kind of AVM can be removed in private hospitals ever. And nobody can remove unless there is a layer of safety for you, layer of comfort zone for you. So every neurosurgeon should have a plaque in front of his clinic saying that there are some patients whom we cannot help, but there is none we cannot harm. We should learn this subject, learn this beautiful subject. We should go on learning this subject. We cannot stop. So what I want to do is, Jayesh, now, I want to show some of my star papers. But what I'll do is, should I show now or should I show later?
Yes, sir. Please continue.
Okay, if you are I will show some of my beautiful papers. This was the paper in 1996 where a temporal craniotomy was included. Something has stopped. Jayesh, can you see? So temporal craniotomy, mastoidectomy was included for the first time in literature in this article. Cavernous sinus, various speculative notes, some beautiful contributions on cavernous sinus philosophy and cavernous sinus surgery. And many of these papers are landmark papers in cavernous sinus. And as I mentioned, during that time, not many people in the world were doing cavernous sinus surgery. And extradural approach to cavernous sinus tumors. This was the first paper in the literature on tumors. Vinco Dollens described vascular aneurysms at that time, but this was the first paper for tumors. Cavernous hemangiomas, one of the most dangerous tumors in neurosurgery, one of the most benign tumors in neurosurgery. For the first time in the literature, we describe extradural approach, and we got a larger series in the world on this subject. Trigeminal neurinoma, my series is largest in the world, and this is the most highly cited paper on trigeminal neurinoma, where we talked about where the tumors arise, how their relationship with the dura, and how you can remove the tumor by working within the dura. For the first time, we introduced the term interdural approach. You see, interdural in 1995. And then there were several, as I mentioned, how to remove the tumor with minimum exposure. You see, this was one of my star papers where I did this tumor by a burrhole in 1995. I must tell you, not many people in the world were doing cavernous sinus surgery. And to remove this tumor from a burrhole and opening the Meckel's cave was a beauty at that time. Even the tumor going in the posterior fossa was removed through a burrhole. Extradural, extracranial extension is also within the dura. Oculomotor third nerve tumors are within the dura. This is a beautiful paper. You must read it. Facial nerve neurinomas arise from the geniculate ganglion and remain within the dura. You work within the dura and you can do a very quick surgery on this. Lower cranial nerve neurinomas are within the dura. This is also one fascinating paper. Chordomas and chondrosarcoma, how the arteries are displaced anteriorly. Cavernous sinus is displaced superiorly. Dura is displaced posteriorly. In 1995, this beautiful article of mine, and on the basis of this surgery on clival chordoma. Supracerebellar approach to clival chordoma, many people are doing now this approach, beautiful. We discussed on several occasions petrosectomy and how to mobilize the facial nerve, and this paper of mine has been referred. on various occasions, very highly cited paper of movement, cutting the greater superficial petrosal nerve and mobilizing these two segments of the nerve. Supracerebellar approach to to petroclival meningioma is becoming very popular. We described it for the first time in the literature. Supracerebellar approach to petroclival meningiomas. Foramen magnum tumors, we describe midline approach, very beautiful, elegant approach, and we have done several papers on this. Pituitary tumors, many of you have heard me on several occasions. I have no hesitation to say that we completely revolutionized pituitary surgery on the basis of understanding of the dural concepts, understanding the philosophy of how the dura is elevated by the tumor, how the dura of the cavernous sinus is elevated, how this entire tumor is subdural or interdural. Beautiful papers. Epidermoid tumors, we introduced the term tentorium-based epidermoid on the basis of the largest experience in the world and work how to remove this tumor. I think a beautiful chapter of neurosurgery. We wrote the largest series of pineal tumors, largest series of endodermal cyst, largest series of tuberculum seri meningioma, largest series of olfactory groove meningiomas in the world. So you can imagine how I used the opportunity to make papers, to write papers, and to on the basis of experience. We wrote this beautiful article on C2 neurinomas as how they respect the dura and how you can remove this tumor. I published in 2008 60 cases and 2018 another 50 cases, and beautiful how I grew in my philosophy on removal of these tumors. Lateral ventricular tumors, largest series in the world, we published 145 cases, big series on intraventricular meningioma, biggest series on colloid cysts, nasopharyngeal angiofibromas, acoustic neurinomas, AV malformations, pial AV malformation, transfalcine, which is quite a popular approach, posterior fossa approach to middle fossa tumors, various flaps we published, brain abscess, some of the astounding work on brain abscess. Then we worked on anatomy on various papers written by my colleagues on anatomy of Pepe's circuit, orbital approach, surgery for technique for craniostenosis, stitches, glioma surgery. We introduced some beautiful, you must have read our recent work on gliomas are confined. This is a revolution in the field of gliomas. How the tumors, low-grade gliomas can be resected en masse, and on the basis of anatomical understanding, fiber tract, how the tumors grow, how the beautiful, you have to complete dedication on the subject, fiber tract, how these low-grade gliomas grow, corpus callosum, and various types of, and spine, of course. I want to just show you some slides on spine. This is, if I have, when I'm talking to young people, I'm talking with on a pedestal, and it gives me pride, and I have to tell my young people that all the techniques, all the philosophies, all the concepts, all the various issues in craniovertebral junction have been referred in my articles. Distraction, basilar invagination reduction, reduction of fixed fixed dislocation, basilar invagination, this concept of vertical facetal instability as the basis of degenerative spine, central atlantoaxial, which is a complete revolution in craniovertebral junction surgery, and Chiari malformation, absolute revolution. Atlantoaxial stabilization is the treatment on the basis of the huge number of patients. So you can see how we said Chiari is a natural protection. We said bone fusion is a natural protection. Bifid is a natural protection. Syringomyelia is a natural protection. Basis is atlantoaxial instability. You stabilize. Kyphoscoliosis is natural protection and related to atlantoaxial instability. Complete revolution. We said foramen magnum decompression can become historical. We introduced this facet distraction technique for degenerative spine, which is a revolution in the field of lumbar spine and cervical spine. And now we talk of only fixation for degenerative spine on the basis of a large number of patients. And we said that there is no need for decompression, only fixation is the need for treatment. And we look at degenerative spine with a different eye. We have talked about degenerative spine and association of atlantoaxial instability. Nobody in the world has ever talked. You see the multi-level, we have talked about central instability of C1, C2, and absolutely no question in my mind that many of these patients with severe degenerative spine need atlantoaxial stabilization. We introduce, you see the beautiful title, that role of stabilization and futility of decompression in lumbar canal. Complete revolution in the field of lumbar canal stenosis. Osteophytes, when the whole world is doing spine surgery for osteophytes, we said they will automatically disappear once you stabilize. Atlantoaxial instability is associated with OPLL on a regular basis. So the treatment of OPLL is complete revolution, no question in my mind. So these are all the statements which I am making are published, and that is my power. So we have said various things. Now, of course, there is an issue of commercialization of neurosurgery. Don't do it. Love this subject. Enjoy this subject. It has an opportunity. It is a lifetime opportunity for you young guys. Go to a place where you are able to do many cases. And that is my message to you. You can change the world of neurosurgery from zero to an ultimate level. Thank you very much. And I hope some of these words could take a message loud and clear. And I hope this is what you wanted from me, Jayesh. I am very happy and very proud to give this egoistic, if you can call, or a proud kind of message. Thank you very much.
Thank you so much, sir. It was absolutely mesmerizing, and always it is so excited and inspiring to. I'm very sure for all of my young my young friends, your message is loud. Of course, it was loud and clear. So what we learn that we should be very dedicated to our field, and neurosurgery should be your first wife. You mentioned that we should be ambitious, opportunistic, and the real neurosurgeon. The gadgets, what we have learned from your slides, that the gadgets like microscope, endoscope, and all that, exoscope and all, these are not the subspecialty. These are the gadgets, and there is no options. It is not the option. We must learn everything. It is not the subspecialty. We should learn everything. And you also mentioned that we should be an academician, and to be an academician, the clinician is not the option, but we all must be academician to grow in our career. And we are very lucky that we are the Indian neurosurgeon, that we have the volume. So we should grow in the institute where we can have a large volume, and we should learn from that. Thank you so much, sir. And that we all are very happy and excited. Sir, please stay with us. We move to the second lectures. Now I would like to welcome Professor Suresh Sakla, sir, for another very interesting lectures. Suresh, sir.
Thank you. Thank you,
sir, before you start,
can
sir.
I?
Yeah, just a minute. So, like Goyal, sir, Professor Suresh Sakla, sir, doesn't require any introduction. We all know very well he is a leader. He's a pioneer in the endoscopic skull-based surgery field. He has done many fellowship at Royal Preston Hospital, UK, Barrow Institute, USA, University of Texas, USA. He's a very well-known academician and teacher. 114 publication, 32 book chapters and 2 books edited. And he's a president. He remains the president and administrative work holder for many national and international societies. So I would like to welcome. Thank you for your precious time, sir. It's very dilemma. It's very important dilemma regarding the fellowship and the observership. So please give a highlight on that, sir.
Thank you, Jayesh, for this wonderful opportunity. And let me first thank Professor Goel for his excellent lecture. It was so inspiring, even for people like me, who have really come across a long way. But yes, some of these things which he mentioned in his lectures are really very wonderful. And we must learn many things from him. He has gone through a very hardship and dedication, and that we all know for last 40 years. He has really made a special way for him in the world of world neurosurgery, and that is what every word that which he said in his lecture is so important and so precious. I would like to really thank him very much for all these things. Jayesh, you have given me a very good topic, fellowship and observership. It is so relevant for our younger colleagues and friends who have just come to a stage, a level where things are not very clear, what to do and how to go about it, and whether to really go about it at all, or just avoid all these things and go into the practice right away. In fact, at our time, 2, 3 centuries back, 2, 3 decades back, in late 80s and early 90s, there were not many facilities and not many opportunities available for all of us, barring few very lucky people like Professor Goel. And even he had to really go to USA and uh, do a good fellowship in skull-based surgery, which was really the demand at that time. When we were passing out, it was vascular neurosurgery phase and the skull-based surgery phase. We were just shifting from a naked eye neurosurgery or loop assisted neurosurgery to microsurgery, and many of the things or the facilities which Professor Goel has also mentioned were not available and to us in our Indian setting. So that time it was pertinent and very important for us to really pursue our interest and our experience and more learning and to achieve more knowledge. The only way was to go abroad, do some fellowship, and then come back with fresh knowledge and the new skills and techniques and technology. And that's what we did at that time. Can I share my screen?
Yes, sir.
It has been not happening. I'm trying for last 2-3 times. Yeah.
Just a second.
So comparing to our time in 80s and 90s, the things have changed to some extent, but more or less, we still have the same kind of dilemma, and people who really come out of their neurosurgery training, they really have to think about it, whether to go for fellowships or any kind of observership. Yes or no, that is a big dilemma. And then what is the purpose of doing all these things? And at what stage of your career that you should do all these fellowship and observerships? And lastly, what is the procedure and how to go about it? So we will just go briefly about each and every steps, and we will take more questions either during or even after the presentation. So the simplest of all is the observership, which means you go to any other department once you have passed out and you have a better understanding of neurosurgery field, and you want to know more, or you want to learn more, have more knowledge, or have different kind of attitude towards neurosurgery. You have the options of doing an observership, which means you go to another department, spend few months or few weeks or few years if you want, and then come back with a fresh look at the neurosurgery, and then you start your practice, which is the simplest way. If you are more interested in learning or spending some time at a particular institute or in the institute department, which you have already thought about it in your during your training, then you can go and do the clinical research. There are several clinical research fellowships available, which means you spend time in a particular department, learning more things, new ideas and new knowledge. And the duration can be 1 month to 2 months
Hello.
Uh,
I think there are.
I think sir has lost his connection.
Let me call.
In the meantime, Rishabh,
Yes, sir.
I will suggest that why don't we have some questions in the meantime so
Yeah.
that, you know.
Sure, sir. The panel is open. I mean, the panel is open for all the possible questions we can have from young neurosurgeons who've joined in today. Any of you who would like to go about with any of your experience, or would like to share any experience, or would like to get your queries answered regarding your recent dilemma, you're always welcome. We have Dr.
Atul.
Pragnesh Bhatt, sir.
Atul,
Dr. Harshad Parekh, yes.
Yes, Harshad, sir.
Atul, you are always an inspirational. You are the only one who has got such a big successful career because of your hard work and dedication. We all came to Bombay like you, but you have grown outrightly like anybody. And your story was beautiful, hardworking, difficult journey, and you have shown the world of neuroscience. So you
Thank
are
you.
an inspirational.
If I just say,
Pragnesh is my colleague. We are all together. You are very right. Nobody was taking up neurosurgery. I joined after Pragnesh joined 1 year later. You were in Nayar. We joined in JJ. Nobody was coming. And they used to say, "Kaun apna sir phodne jayega udhar?" This was the time when we started with carotid angiogram in the night. Whole night we are doing angiogram. PEG, myelogram, inject the myodil. See, these were the days, and you have come up to this level, and wonderful, wonderful. It's a great honor for us to be with you. And Pragnesh is also our colleague. He has also vouched you for all these years, and amazing stories. And you are now beyond all these things. Not only the youngsters, but we all should learn from you also and take some inspiration, more inspiration to learn.
Thank you, Harshad.
You are an encyclopedia.
Thank
As
you,
I
Harshad,
always say.
for your nice comments and for your affection
Not
and
right.
for, you know, for your. I
I
cannot.
always say Atul can operate in a blood also. He can see the things when bleeding is also going on.
Thank you,
Nobody
Harshad.
said. Today only I talked to Pragnesh in that way. He can see how he can see because God has given him the brain.
Yes, Pragnesh.
he says he has got 10 eyes. He sees with his fingers. I remember that. I just want to say one sentence.
Yes, sir, Pragnesh.
Thank you very much, Dr. Sardara. This is a fantastic. I was just putting a twist on the title that Atul is a cool guru of neurosurgery Gurukul. And Atul is known by this John Bennett and everybody else in this neurosurgical TV as king of webinars. Well,
Yeah.
I can tell you, if he's the king of webinars in delivering, I am king of webinars attendance. And I'm sure
Yeah,
Atul will agree.
absolutely true.
I can repeat most of Atul's webinar. C1, C2 is a fantastic and unique and most underestimated and whatnot. But I must say that of all the webinars, including some philosophical, I have learned maximum. It was inspirational, Atul. Honestly, your humility and your respect for your teachers and for the people you have learned from, where you have come. It was outstanding. I have no words, but I could not resist. So we are very proud, and we are, means it was an honor that Atul graced my institute and my home for a day in 2018. This is still considered as one of the best days of our life in Aberdeen. So thank you, Atul. Much obliged.
Thank you, Jayesh, for your affection, your presence, and for your will to learn. Even nobody can say that there is an end to learning process. We have to keep on learning. And now today I am actually 63 years of age, but I can tell you that I feel that I'm very young still, and there is no question. I'm the strongest. I have, after I have finished from KEM, I'm going to gym, I'm doing exercise, and I'm doing fitness, and my muscles, if you come and see today, they have never been so strong. And unfortunately, I can also tell you, and this is a message from my heart, that I have never been happy after I have left KEM. I've never been happy. I have always, I should not say I have been crying, but it is to that level. I am trying to find my volumes by running from one hospital to another hospital to another hospital. Now I am attached to several hospitals. I am trying to hunt for cases. I am running from one corner of Mumbai to another corner of Mumbai. I am going from one city of India to another city of India to hunt for patients. I'm spending a whole lot of time. I have never been actually happy. And it may not be wrong to say that I have not stopped crying after I have left KEM. And I wish I can get back in KEM. But it is, a very nasty kind of situation of our whole system, where you retire a person. They gave me extension of 3 years, but that was not such a, people want to have their own careers. They want to have their own style. They don't want to have somebody imposing on their freedom of working. And it is understandable. Careers are built, and I think that my career was also on an ascending phase of my life. And suddenly there has been a big break to that ascension of my career. I'm still operating a number of cases in Cooper, in Somaya Hospital, in Leelavati Hospital, in Bombay Hospital, in various places. But that happiness has never come my way. And I hope that I will again start getting my happiness back. But those who are looking for happiness, those who are looking for avenues, the first thing that you should look for is a good place where you can use your skills to the maximum. You can use your skills to maximum number of patients. Don't go to a place where you can earn the maximum. Right. Go to a place where you can do maximum and your work is relevant. The advantage of private hospital is that you can instantly get independence. The advantage of private hospital is you can immediately look for your own views and your own ideas, and you can use them for the patients. But only thing is the life is at stress. So you try to learn how to avoid that stress, try to do as many patients, try to continue working on cadaver labs, try to innovate, try to think, try to publish. These things, if you leave apart, you cannot go beyond a line, which I have seen in my life. Like if you don't publish, if you are operating, you are a fantastic surgeon, you can give fantastic neurosurgery. But if you want to go beyond a line, you have to simultaneously publish, simultaneously think, simultaneously innovate. As I have said, you do not require to be an extremely intelligent person. What is required is your ambitiousness. What is required is your aims in your life. You know what? You'll be surprised that many of you may be knowing Dr. Ravi Ramakant, who was a very fantastic radiologist of India and of our country and of KEM Hospital. In his room, there was a mention, which I read in 1984 or 85. He had written, not failure, but low aim is a crime. So we should not have low aim. So I can see that Jayesh has given a message that we have to start with Suresh Sankla again.
Yep,
Uh,
I can. Shall I share my screen again?
yes, sir. Yes, sir. You can start again where you stopped, sir.
Okay.
Yes, sir. You can
Oh,
start.
still not
Yeah, yeah, now you
sharing.
can.
Okay, now got it. Okay, so sorry about that technical glitch, and so we were talking about all these kind of experiences that we can have after passing the exams and clearing their training program, and then before going to your next assignment, which is practice. Okay, so what is the difference between the observership and the fellowships is that, observerships are usually short term, usually not more than 1 to 3 months, and actually they are enough for that duration. In the observership, you are supposed to have clinical observation in the outpatient clinic, in the operating rooms, in the neuro ICU. You can also attend to the hands-on labs if that department has its own. You can participate in the clinical meetings and discussions. However, there is no direct access to the patient or the patient records in the observership. However, the admission process for the observership is pretty short and simple and easy to go through. The most of the observerships are non-paid, and accommodation is a problem most of the times. Some of the departments have temporary accommodation, but most of them are not. The good thing is that since there is no interaction with the patients and the patient's family members, you do not require any language learning or any change in your language qualities. As opposed to this, the fellowships are usually meant for 3 months to 3 years time, and you're supposed to take active participation in the departmental activities, whether it is outpatient clinic or operating rooms or ICUs or wards or labs. You have a full access to the patient and the patient records and all investigations. You are involved in a regular work rota, which you are supposed to perform as your other colleagues are performing. They are most of the time paid fellowships, and the accommodation depends on the type of the
I think sir has got disconnected again.
Yeah. There are network issues, so he may join again. Well, sir, I feel very sorry to hear that you are missing that large volume centers, but what we there is one question personally I would like to ask. Once we become a pass out, and then there are a common dilemma, we have been under pressure that somebody you start subspecialty, you focus on subspecialty, you do fellowship on particular subspecialty. Is it right to start and focus on subspecialty from day one, or should we learn all the general neurosurgery and all the gadgets for 4 or 5 years, and then we should choose subspecialty and focus on that? Government or private, whatever.
Jayesh, I can understand what you are saying. You see, there are some specialties like peripheral nerve surgery. That is a different, complete different. like a specialty of pediatric neurosurgery where you're doing craniofacial surgery. That is a different surgery. But in general, tumor surgery, vascular surgery, spinal surgery, they are the cream of neurosurgery. They are actual neurosurgery. Now, you know what? You know Peter Janetta, of course, you know the man who
Yes, sir. Yeah.
did microvascular decompression and all. I was with him for a period of time. And he told me that you should be good in everything. You should be good in everything. But you should be very good in one subject, or you should be specializing in one subject. This was his sentence.
Right.
As far as I am concerned, and as far as I think about neurosurgery, like you have to be a good surgeon, okay? You have to be good, like tumor you are operating. If you are good in operating an acoustic tumor, if you are good in operating an acoustic tumor, you can be very good in operating intramedullary spinal tumor. You can be good in operating on foramen magnum tumors. You can be good in operating on cavernous sinus tumors. If you are good in operating on cavernous sinus tumor, you can be good in operating on gliomas. If you are good in understanding the anatomy, you can do craniovertebral junction surgery, which is a difficult surgery, as you know, but it is a very evolving subject. I will still say that you should be specializing in craniovertebral junction surgery, you in particular, I'm saying, because you have got a basic work and you have got some fantastic papers, you have got understanding, and craniovertebral junction is a difficult subject. Not many people in the world are doing craniovertebral junction surgery, real craniovertebral junction surgery. I think it is a good opportunity, and you make your name, you start advertising your work, you start talking about your work, you start giving lectures on craniovertebral junction, and you should specialize in craniovertebral junction. This will be my recommendation, because for people, a young person like you can, develop further in this field. And if you are good in craniovertebral junction, you can be good in spinal surgery. You can be good in disc surgery. You can be good in understanding the nitty-gritty of spine. So my feeling is that if neurosurgery, you cannot say I will leave spine and I will work only on brain. You cannot say I will work only with, gliomas. You cannot say I will work only with malignancies of skull base. Or you cannot, divert. I will say do everything. This subject has many things to give you. Pediatric, you cannot say I will not do medulloblastomas. I will not do this tumor or that tumor. You will do everything, but when you are in a department, like where I was, you have to make specialists of everything. You have to make some people good in some things, and they should be then talking about that subject throughout the country and throughout the world. So, but when you are in a private setup like what you are now, I think for you, it is very important to do everything. And every case should be a challenge for you. Every case should be a difficult case for you. Every case you should study properly, like you are studying, like you are giving full time. You should never be so busy that you have not studied your case properly. If you are doing a temporal tumor, you should be exactly knowing where the tumor is, where your incision will be, how you will decide before the operation. So a person like you and a young person who is, developing or evolving in the field, every case should be a learning case. Every case should be a challenge, and every case should be delivered. Everything has to be delivered, because, in private hospitals, particularly, if you don't deliver, you can be in big problem. You don't have that, cover or a protection barrier for you. That is the issue.
Right, sir. Get it. Why I have asked that particular question, because many more residents and young neurosurgeons may be in the dilemma and the same things. So, Dr. Abida is here, if she can listen. Dr. Abida, please welcome. Professor Abida, if she is listening.
Yes, Jayesh, I'm here.
Need your comments.
Hi, Jesh.
Hello.
First of all, I have been quite lucky that I was under KM Hospital under Professor Goel, and I have been trained by him. So that is worked to a great advantage. But I completely agree, K. If you have the opportunity, you should be working in a public hospital because that gives you the kind of confidence and and continue to do academic works. And as you know, I like anatomy. I think for all of us, anatomy is important, and we should continue learning anatomy. It should never stop because every time you do some anatomy, you learn something new and something different, and it's quite fascinating. So that is what I would like to say, that don't leave this subject. And of course, Professor Goel is one of the best teachers in the world. That is all I can say.
Yeah. I really admire your work on white fiber dissection. I have heard many lectures for you, and we really agree that, of course, the neuroanatomy should be the basic thing. We have Dr. Sachin Borkar. Sachin boss, are you there? Okay, house is open for any comments. Yeah, Rushabh, please go ahead.
First of all, I'd like to thank Professor Goel, sir. Thank you for gracing our forum with this fantastic lecture. Continuing with where Professor Jayesh left, I like to ask two things. With the clutter of information which we have in the current generation, with I think there is a blast of online lectures, there is a blast of people showing so much of work, be it vascular, be it tumor dissection surgeries, be it white matter surgeries, be it spinal tumors. It becomes a bit challenging and bit difficult for a resident in government medical colleges, not probably in Mumbai, but maybe in some tier 2, tier 3 cities. How is it? How are they going to? How are they going to understand what is their liking or what is that they need to specialize in, first of all? Because with the amount we come in a generation of social media where we are fascinated by whatever is shown to us, and especially with professors like your standard, sir, your standard, we see a lot of vascular work. Also, we see a lot of tumor work which is coming on by Neurosurgical Atlas on social media. How do we decide whether our actual liking stays, is whether in the vascular surgery or in the spinal surgery or somehow, and how do we approach once we are out of our MCH neurosurgery residency in tier 2, tier 3 cities, go up or approach some government medical colleges, because again the posts are not vacant and it becomes very difficult to apply, and there are many places where for a single seat there would be probably 5 or 10 applications coming in. So how to go about that in such kind of a situation?
See, one thing is, what these webinars, these webinars are a unique thing. Unique means if you are sitting in any remote corner of the world, if you have internet, which is there in every remote part of the world, you have the access to topmost information of the world. Like you can listen to, suppose, any person in the world giving in US or in any, you can sit down in the comfort of your room and listen to what he's saying and then analyze that work. And this opportunity, suppose these webinars were not there, how many of us would have been able to go to US or to go to Germany or go to Japan? Maybe we could have gone once in a while. But now if you sit down on the computer and see even from the archives, you can get any subject, anybody of importance in the world, and get that information from what he has to say current. So this is an opportunity which was not there earlier.
Yes.
And we should use this opportunity. We should not get ruffled by this opportunity. If somebody is showing bypass after bypass, you would say, well, we don't need this kind of thing. Somebody is showing AVM after AVM after AVM, you will say, we don't get disturbed. Oh, I cannot do AVM surgery. And what is this, So you have to make use of whatever is available. make use of whatever somebody is talking about. Understand, you must also understand that when somebody is giving a lecture, there is a element of showmanship in that lecture.
Agreed.
You should not get
Totally.
unnecessarily disturbed by that lecture. Oh, I'm how I will reach, and I'm working in India, and I am working in a poor country. This should be the last sentences in your mind. That is one thing. Second thing is, you have been trained in a good center with a very fantastic exposure in everything, in tumor, in vascular, in endovascular, and you have learned from whatever you have learned, and you had the opportunity to see whoever you have to see. And now is the time. Now is the time for you to take a direction and take a, jump into the field. This is the time. And you have to, as I have told you, neurosurgery is not a profession. It is a way of life. It is life. You have to live this subject. You have to work hard in the subject. You have to continue to learn, and you continue to progress. And that will depend on what opportunities you get, where you get, how you get. That you have to think about. And think about the first thing I told in my own presentation, I said, low aim you should not keep. You should keep the highest aim. You have come into neurosurgery not because you have come because you are an ambitious man. That is why you have come into neurosurgery. All the young people in the audience are ambitious. That is why they have landed in neurosurgery. No ordinary person can land in neurosurgery. So have that pride, have that ego, and continue that ambitious nature. That will be very important for you to build a career in this neurosurgery. It is a difficult world, all right. It is a dangerous world, all right. It is a world where you can be incriminated in, you do some tumor and you do not produce good results in a private setup. That is one issue. You have to be result. You have to give result. You have to be trained enough to give result. You have to do fellowship. You do fellowship. You go to anybody, you do it, whatever. But when you are in the system of a setup, you have to give results. And you have to have that kind of power to give results. You cannot be artificial in neurosurgery. You cannot be half trained in neurosurgery. You cannot be untrained in neurosurgery. You have to be fully trained, because people are watching you. You do one wrong disc and you don't realize that if you are in a private setup, you don't do a disc surgery properly, you will be not able to sleep, because other doctors are there to say, oh, what nonsense he has done. Oh, what foolish operation he has done.
Yes,
So,
sir, I was about to come on to that question exactly. How do we deal with the frustrations post-surgery if the surgery is not gone well, be it in a government setup or in a private setup?
First message that we should give to our people in neurosurgery is, if suppose Rishabh has done some surgery, don't comment on that surgery when the patient comes to me. Suppose Rishabh has done one lumbar canal stenosis and he comes to me, and I start saying, this fellow knows nothing, he's done wrong operation, and this is the language people use in a private setup. So first thing that we should teach our young people, old people, senior people, that we should respect our colleagues. If we do not respect our colleagues, you will have one day where you will be, having a similar situation. So it is very important, Rishabh, that first thing is we do properly. Second thing is we be critical of our own work. Like if you have not done it properly, next case should be done properly. And the third thing is, if somebody has done something here and there, you should be respectful. We should respect the other individual. And never, if somebody is talking negative about somebody else's case, he should be punished in forums like this. He should be shown, his face should be shown in forums. Like, this is I had done, and this statement has been written, given by this doctor about my surgery, and this is not correct. You should expose these kind of people. Unless you do it in a very aggressive fashion, this thing can distort a young person. Like, I even say that I am also young. You are young, all right, but I am also young. If I am doing some operation and somebody goes to here and start talking nonsense, we should be very, very careful about this personally.
Well, sir,
Yeah.
Dr. Karthik has asked one question here.
अभी भी response नहीं है इसको.
For fresh
Oxidation.
out neurosurgeon, we are not having vacant position in institutes, and fellowship have a very highly competitive intake. Last resort we are left with is freelance in some nursing home or join as associate in some private hospital where hands-on is almost nil. How to cope up with this frustrating environment and build a practice for ourselves? A very interesting question, and it must be a question of lots of joining as a private practitioner. So, any message for them, sir?
Message number one is wherever there is a will, there will be a way. Okay. If you want some place where you want, you will get. Don't have feeling that you will not get. If you want to join a private setup, there are good private setups, good places where you can build a practice and you can build a good name. There were at one time, many of the young Indian neurosurgeons used to go to smaller countries like Saudi Arabia, Oman, and this and that, where they were getting good salaries, but they were being treated as second-hand citizens of that country. They were treated very badly, but they used to get good money and marginal exposure. So I used to say very strongly at that time that there is no need to go to countries like these countries where you are treated like a second-grade citizen. In India, there are many opportunities. Even my residents have made big, beautiful hospitals where they are fantastic hospitals. Many of my residents have made, and they are doing good work. So have vision, have stars in you look ahead. And don't, have negative feelings. You're a neurosurgeon. You're a big man in the society. That pride you should have. You're not small person. If you think that you are a big man, walk with pride. I used to tell my residents, when you walk in KM hospital, by your walk, they should know that he's a neurosurgical resident. That kind of pride should be there in you. So one thing is have pride, you become a neurosurgeon, opportunities will come, and look for good opportunities. Wherever you want, you will get. Whichever fellowship you want, you will get. Be after that fellowship. Don't, if you want, suppose vascular fellowship, you want to go to this place, you will 100% go on writing letters, go on getting certificates, go on writing to that man, whoever you want, and ultimately he will give you fellowship. If you write once and he does not respond, you don't stop. You write him again, 10 times you write, I want to come, I want to come. Another beautiful thing I want to say, which I mentioned today in my department, in my operation theater, that no neurosurgeon will ever go hungry. No neurosurgeon should ever go for, marginal small bits of money here and there. You should not go. You are a neurosurgeon. That itself is a big money for you. You should, money should not ever be a troublesome thing for a neurosurgeon. You look for opportunities, you look for good opportunities, you look for good work, and you do good work. That is the basis.
Right, sir. Dr. Borkar? Dr. Borkar, to tell something.
Sir, Dr. Goyal, thank you very much for an inspiring talk. I just wanted to ask, nowadays there are many seats of DNB neurosurgery, MCH neurosurgery across India, and the hands-on which a resident used to get previously has considerably come down because of the number of seats. So the amount of exposure they get is less, and after that, there are not enough positions in government to practice what they have learned or whatever lacunae in training they had. So that's a real systemic problem, sir. So what should a young person who has just finished practice, he obviously jumping in private directly without adequate or unless he becomes confident is an issue. So what do you suggest to such people? Because already with a lot of bonds in many states, their effective age at which they pass out MCH neurosurgery and get into practice is already a bit prolonged. So what is your opinion on in such a scenario?
Sachin, you know, and I know that it is difficult. Neurosurgery is not easy. Neurosurgery is a commitment. Neurosurgery has to be learned by operating. Neurosurgery has to be learned by repeated operations. So we have to, as young neurosurgeon, we have to keep our eyes open, our ears open, our heart open, our legs jumping, and find that opportunity, find that place where you can do operation properly and with comfort zone. You see, you should not be stressed. Suppose Sachin, I say to a young man, okay, you have passed neurosurgery, now go to a private hospital. And suppose he lands up with a case of acoustic neuronoma. He has never done an acoustic neuronoma. So what he will do is he will refer here or refer there. That is one thing he will do. Second thing, he will try to do the operation on some patient and he will create a complication, or he will do half job. He will do I'm not saying young people cannot do. You don't misunderstand me. I have already told you that a young mind is a very fantastic mind. We should not think young and old. Is nothing in neurosurgery. Even a young person can do a fantastic surgery on acoustic or whatever surgery comes his way. But if you have gone into a private setup without enough confidence and you are landed up with a case where you are not able to do, you can have a very miserable time. You see, that is my worry. So I will have to suggest that if you have that kind of situation, you want to do private neurosurgery, you must do private neurosurgery. But before you do enter into a private setup, you find an opportunity anywhere in the country, there are many institutes which are coming up, many kinds of aims which are coming up in the whole country. And you find out where the new hospitals are built up, public hospitals are built up. And I will say the best way to learn neurosurgery, best way to advance in neurosurgery is to work and get opportunity in a public hospital. And I will not be true in my message. I will not be correct in my message if I say after MCH, you jump into a private setup. You can have a miserable life. You see, looks like initially you may see some money here and some money there, but you create one complication here, one complication there. There are others sitting in various institutes to point on finger on you. You do one OPLL and the patient becomes quadriplegic and you will be bombarded with criticism from your colleagues. So you have to be, to land into a private setup as a young individual. There are many people young who have landed in private and they have done good. They have built hospitals. They have made good careers. But it is not easy and everybody does not get success in those things. You can go for fellowship. You can go and learn from various people in India. Why foreign fellowships you are talking about all the time? There is no need for foreign fellowship. I have told this thing. When I was a student, the only thing about India people used to say that we cannot do because we are poor country. We cannot do good neurosurgery. This was the attitude. And in 1987, I have got a recorded message to Bangladesh neurosurgeon. At least 30% of neurosurgeons in Bangladesh have been trained with me or more. And I gave a lecture in 1986, which is recording. And I said to Bangladesh neurosurgeon, the best neurosurgery should be coming out from Bangladesh with so many patients. So this negative attitude, like we in India and foreign fellowship and this fellowship, this kind of thing should not come. Of course, in India, if a fellow goes from this city to another city, we don't treat him properly. We don't behave with him properly. If we do not behave with our own children properly, how can you expect a person going to America and being treated properly? So I must tell you, when I went to England for the first time, I got a feeling that because I am Indian, I'm not being treated properly. This kind of feeling, which may not be correct, but I used to get that kind of feeling. But now you should behave Indian and talk Indian and blast India out. Yeah, no, you heard from my lecture that I am this, I am that. You tell me, where was the non-Indian thing coming on? Where was inferiority complex there? There was no inferiority complex, the only superiority complex. So we talk in that language. Don't talk in negative, submissive language.
Yes, sir. Thank you very much. I think I completely agree with you regarding the fellowship opportunities, and India is very well equipped and very well good mentors who can actually teach and give more hands-on than a foreign fellowship. So probably that's the way forward. One more question, sir. What is your suggestion for young people, even they after spend maybe 4 or 5 years after MCH, uh, especially if they wish to stay in a metro city, even 5 years post MCH experience may not be considered enough for people to stay in metro city or something like that. So they will have to probably move to a tier 2, or and now the situation is such that even tier 3 city, even tier 2 cities are quite saturated with neurosurgeons. So any opinion or any suggestion for young people?
See, for young people, you have to know that when you are entering the market of neurosurgery, when you are entering into a private neurosurgical setup, you have to show your class, you have to show your power, you have to show your advertising skill, you have to show your marketing skill, and more important than anything is you have to show your clinical results. You have to have that confidence. If you have the confidence, only then you can talk. If you don't have the confidence, you will not be able to talk. So there are people, like I will say that Jayesh, for example, Jayesh has done a lot of academic work. He's fully matured neurosurgeon to work in a setup and build up a career in a private setup by talking, by interacting, by it is a different world. He has entered into a different world. And you have to, if you have entered, you enter with confidence, enter with pride, enter with skills, and show to the world that what you can do and build up your career. You see, not all everything. How many full-timers in institutes have really blossomed into fantastic? It is not that everybody in only in academic institutes become big. There are many people in India and various countries where people have become international class by working in a private setup throughout their life. It is not that private is a negative. I'm not talking private as a negative kind of thing. But when you are entering into a private setup, you are entering into a market, you are entering into a business of neurosurgery, you are entering into a different world of neurosurgery. So you have to have that kind of attitude towards neurosurgery, and you have to be positive, and you have to give good results. That is another very important thing. As I mentioned to you, results is what matters, and results is what will show and what will take you further in your life. Whether you are in academics or in your private, that is one thing. So you have to learn, and you have to be a good neurosurgeon. And neurosurgery, if it is your life, you will become a good neurosurgeon. If you are thinking all the time as to how much money this fellow will give you and how much money you will get from that patient, if you are thinking in those lines, you can definitely not become a neurosurgeon only. You will become like a foolish idiot sitting counting money. So if you want to look like a solid person, like what I can see on the screen, Sachin, like a solid, confident person, only by your work you can show your confidence. If you say, I have made a new car, I have made a new house, I say, go to bloody hell, what new car of yours? You show your work and then become big.
Right.
Yeah, right, sir. Thank you very much, sir. I think that insight is quite important for all the people who are listening.
What I like, one things when you walk, as girls will say, it should appear that you are a lion, you are a neurosurgeon, and everybody should appreciate. That's what I like. Okay, Dr. Pragnesh, you want to say something about the imbalance in the UK, and he just would like to say about comparison between UK and Indian neurosurgery field. Yes, sir.
Thank you very much, Dr. Sardara, for giving me this opportunity. I feel very much at home. I am one of you, though I may be in a different part of the world, but I am one of you. And I appreciate everything that you are doing. Let me tell you one thing. Currently, India is blossoming and blossomed in neurosurgery, and I think you all are doing fantastic job, and there are lots of opportunities to learn. And if it is allowed, I would like to send my residents for fellowships there. So that's the first thing which I echo what Professor Goel said, number one. Number two, the answer I wanted to give to Dr. Borkar's question was that the onus about these opportunities and imbalance lies with the senior members and the NSI, because we have missed the opportunity and currently we are suffering. There are 60 to 80 fully accredited, board certified, what we call CCT neurosurgeons in Britain without job for somewhere between 3 to 5 years doing fellowships, because there are no consultant jobs available. People like me are not giving up, which is bad thing. I'm thinking to anyway. So we have stopped admitting. We have a run-through program for 8 years, and normally we used to have per year we have 30 to 32 centers in Britain, and we used to have 30 to 32 admissions every year into the program. For last 2 years, we are only admitting 15 trainees because we don't want 100 trainees coming out at the other end with no jobs. So I think this is a very real challenge, that when there are more neurosurgeons and more training places and not enough placements for faculty or for practicing. The other option that I trained in Mumbai and in UK, but was practicing in Ahmedabad for 10 years very happily, not substandard, doing everything fantastic, as Professor Goel says, in my own world in 90s. So sometimes not going to a not a very popular or known places are also a good consideration. I know you said metro cities was the word used, and there are people I know, correct me if I'm wrong, but there are people working in Northeast. There's lots of opportunity in Northeast of India. If I'm correct, there is somebody called Digant Kamdar from Britain working somewhere there. I know a lady who I was faculty in Guwahati outreach event, and that time there's a lady working in there in the Northeast. So there are, and I know some of my seniors who went to interior of Gujarat, like Dr. Moda and Dr. Kirit Shukla, my seniors, they are kings. So yes, there's sometimes the quality does suffer, but as Professor Goel said, that private is not necessarily an opposite of academia. We have a proof of Professor Misra, world leading neurosurgeons in private sector. But I agree, the main thing I wanted to share was that the onus of imbalance is with the seniors and with the society to make it correct. But India has got fantastic neurosurgeons, fantastic institutes, and fantastic training program. And if I have a choice, I will send my trainees, or I myself will come, and I do regularly come to learn and listen to all the webinars that you all are doing. I'm very proud of you. I am one of you, and I would like to connect with you all the time. Thank you.
Thank you, Pragnesh sir. So, well, sir, Dr. Suresh Sakla sir has sent the message that because of network issues, we will not able to join, and will listen his lecture on the next series. So, on behalf of all the INSRAP group, well, sir, we are very grateful to you that you have spent the time in this schedule, and thank you so much. Rishabh?
Yeah, I agree with Dr. Jay sir. Very enthusiastic lecture, sir, and very motivating for all the young neurosurgeons. I'm very hopeful that we've, as a group, as a forum of INSRAP, we've tried to address a single dilemma, though we could not go ahead with the other lecture of Professor Sankla sir due to some technical adversities. But I think once and for all, we have this single dilemma settled, that whether to go ahead with government practice or for private practice. I think it is very important for us young neurosurgeons to weigh the balance, the pros and the cons, and to understand the intricacies of government practice, and understand the numbers, the load which we are going to get in government, we are never going to end up getting in private. And that is how we are going to excel in government as well as in private practice for that matter. So thanks a lot for your fascinating words, sir. We like to have a small picture. If all the panelists, all the participants who are there in the forum right now, if they can switch on their videos, we can have a quick photograph for the session.
And it's
I would request Pragnesh sir, Abhida ma'am, Harshad sir to switch on the cameras, sir. Is Dr. Pragnesh sir still with us?
take a photograph, Rishabh.
Yeah.
Yeah.
Very
So
much.
I think
very
on a
much.
count of 3, we'll click a picture. Yeah. 3, 2, 1. Yeah.
Thank you. Thank you all.
Yeah.
Thank you.
Bye bye. Bye bye, everybody. Bye bye.
Bye, Atul. Bye, bye, bye.
Bye
Take
bye,
care.
Arshad. Bye bye,
See you.
Pragnesh.
See you.
Bye.
Some of you next week in Mumbai. See you. Thank you.
Thank you.
Bye bye. Bye bye.
Arshad, thank you.
Bye, bye. Bye, 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 bye. Bye, Jayesh.